Okay, I'm going to make a start because we've got an hour today. So I'd just like to welcome everybody to this webinar on caring as a social determinant of health, who experiences the greatest impacts and what works to support older carers. This is part of a monthly webinar series, which is hosted by the National Institute for Health and Social Care Research and Policy Research Unit in Healthy Aging. So we were formerly named the Older People and Frailty Policy Research Unit. So in this webinar today, we've got 4 presentations, one from Gemma, one from Alex, then Laurie, and then myself. I'll also be presenting towards the end. And we're going to do Q&A at the end, or give an opportunity to ask some questions at the end of each presentation. I'm standing in today for Professor Barbara Hanratty, who is on leave this week. My name is Jane McDermott, and I'm head of, I lead on public community involvement and engagement, but I also am head of collaboration and impact for the Policy Research Unit more broadly. So throughout the webinar, whilst we're presenting, we will be posting any related publications into the chat as we move through, so that'll help you kind of navigate what we're presenting with any published articles that you might find you'd like to read more about. As noted, after each presentation, we're going to pause a little bit to provide an opportunity for Q&A. And I'm just going to ask you to navigate your screen now. So you should probably at the top of your screen, but it might be at the bottom, depending on whether you're using a tablet or a laptop. You'll see that it's got a Q&A function, so it's got a question mark. If you press that option, you should be able to post questions there. If you see a question that you really like and think would be good to somebody should ask, then please give it a thumbs up, because that helps us monitor which questions to ask as they move up. I will point out, in previous webinars, we've found that not everybody can access the Q&A function, and that is just to do with firewalls and different institutions depending on where you're based. If you find you don't see that, please just post questions in the chat, and I will try my best to make sure that I integrate them into any questions for today as we move through the sessions. At the end of it, I would ask actually that we are going to be recording this webinar today. Once we've recorded it, any questions also that we've not been able to ask during the session, we will prepare a brief document which has the question and our response as a team. So that will then be shared with everybody that's attended, but also everybody that registered. And actually, you can all access that in the future, and it will be posted on our YouTube channel. So I'm just saying, I think Linda is going to start the recording just to make sure that we're ready to go and that we can move forward. Hopefully no one's got any questions, and so I'd like to move on to the first session, which is going to be from Gemma. So Gemma, if I pass over to you, thank you.
Yeah, thanks, Jane. Hopefully everyone can see these slides that I'm sharing. So I work at Newcastle in the Healthy Aging Policy Research Unit. And just for those who don't really know much about us, a bit of background, our goal in HAPRU is to generate evidence that will help people to age well and to ensure that healthy aging is as equitable as possible. And we look at this from many different angles. And one of those angles is unpaid care. So in this presentation and the subsequent presentations, when we refer to unpaid care, we're talking about friends and family members, people who are supporting friends and family members in a non-paid capacity, providing any amount and any type of care. So we know that unpaid care is not exclusive to older populations, but if you look at data from the UK Census, we do see that most carers are in the 50 to 64-year age group. We also know that as more of the population grows older, and as social care struggles to keep pace with demand, more and more people are going to be providing support to their older family members. And we also know that more and more older people are providing unpaid care to children and working age family members. So unpaid care is not exclusive to ageing populations, but it is a critical part of the healthy ageing picture. So in the UK, we have a long history of doing research around unpaid care, and this is a vast evidence base. When we started thinking about our work in this our work in this space, our first question to ourselves was, how do we as healthy ageing policy researchers most usefully contribute to this evidence? And our answer was, as a starting point, a scoping review. And this is so that we could try and get a feel for what's been done, where are the gaps, and what gaps can we address going forward in our future work. So these are our scoping review aims. We wanted to identify and describe what studies were available that was telling us something about who unpaid carers are. We wanted to identify and summarise evidence about the impact of unpaid caring. And we were interested in whether there was any evidence that told us which groups of carers were most likely to experience the worst impacts. And we were also interested in whether there were any studies that had explored the impact of unpaid caring by socioeconomic status or area deprivation. I'm not going to go into a huge amount of detail on the methods, but I will just highlight a few key points. So we were interested in carers of older people and older carers. And in this work, we operationalised older as 50 years and over. And this is just in recognition of the fact that age-related poor health occurs earlier in the life course for the most disadvantaged populations. We were interested in any measure of health, quality of life, social outcomes and economic outcomes, and we looked at UK observational studies published from 2000. So to synthesize this data, we used EpiMapper. If you're not familiar with EpiMapper, it's a really neat little tool that produces we call them maps. They're basically matrices of evidence, so you can clearly see where the gaps are. And in all the subsequent slides in this presentation, you'll see a link in the top right-hand corner. The link will take you to the map, so you can look at those maps at any point, but it isn't necessary for findings that I'll present. So if you want to look at the maps afterwards, you can do. So we created these maps of evidence, and we also used a narrative approach to summarise the evidence. So we found 85 studies that met our inclusion criteria for our scoping review. And the majority of this evidence was about older carers. So I'm just going to move my little window so I can see properly. The majority of the evidence was about older carers, but as you can see from this, for most of the studies, they didn't tell us who they were caring for, whether it was children or adults or both, and that most likely reflects the data that were available in the cohort studies that were used for the analyses in these studies. The bulk of the studies that we identified were also telling us something about the outcomes or impact of unpaid care. And there was a chunk of evidence, not a huge chunk, but a chunk of evidence that was telling us something around which groups of carers were experiencing the worst impacts. So for the remainder of this, For the remainder of this presentation, I'm going to talk about the evidence that was around the impacts of unpaid care and which groups were most likely to experience the worst impacts. So when we look at the evidence around caring and health, we see that greater caring intensity, which is typically measured in the hours of care per week, greater intensity of caring was associated with poorer health on a range of outcomes. But there was also a chunk of evidence that was looking at the link between caring status and health. So caring status is just whether or not you provide unpaid care. And that bit of evidence is much more inconsistent. And we think that caring intensity as a measure is probably offering a more granular picture about what's happening for carers and their health, whereas caring status alone might be a bit of a blunt measure. There was evidence that caring and greater intensity of caring was associated with poor quality of life and decline in quality of life over time. And unpaid carers were working fewer hours. They were more likely to leave paid work early. They had reduced pension contributions and a smaller state and private pensions. In terms of which groups of carers were experiencing the worst adverse impacts, we see that in terms of health, it was high intensity carers, single carers, those who are caring for partners as opposed to those caring for parents, carers in poor health and carers with low levels of social support that were most likely to experience the worst kind of health impacts. With social wellbeing outcomes, including quality of life, there was a lot of variation and we couldn't really get a consistent picture, but there was some variation in these outcomes by what type of relationship there was between the carer and the care recipient, and whether the care recipient had access to formal care and participated in social activities. For the socio-economic outcomes, it was consistent that female carers, single carers, carers in poor health, and carers who experience some financial difficulties were most likely to experience the worst socio-economic outcomes. Although we did find a good chunk of evidence around which groups of carers are most likely to experience the adverse impacts of unpaid care, a lot of these effects were reported in single studies. And so there's still, we look at this as researchers and think there's actually still quite a lot to unpack about which groups of carers are most likely to experience the worst impacts. So in terms of gaps, although we found a lot around health, unpaid caring and health, very little of the literature, of the evidence base, is considering disability outcomes, and very few studies are considering the health trajectories of carers over time, which is important when you consider how unpaid care tends to fluctuate over time. And there were still some groups of the population where we're not really seeing much in terms of how unpaid care affects them. So, for example, by ethnic group, for example. Social outcomes and quality of life for carers, there was a little bit of evidence there, but it wasn't offering a consistent picture. So there's probably a bit more there to unpack. And certainly we found very little about how all types of impact of unpaid care was varying by socioeconomic status and area deprivation. I mentioned earlier that the bulk of evidence was about older carers, and there was relatively less evidence about carers of older people. So we think this is also a gap that could be addressed going forward. So I'm just going to run through some implications of this work. So we did this really so we could try and get a sense of where are there gaps, where can we contribute going forward as a Healthy Ageing Policy Research Unit. So certainly I think there's more to be done around understanding health trajectories of carers, whether that's older carers or people caring for older people, and understanding which groups of carers are most likely to experience the worst impacts. I think we probably need to find out a bit more about who older carers are caring for, as this might have implications for their needs and how they want to be supported. And I think just as a methodological consideration going forward in our work, it's really important that we try where we can and where data are available to consider caring intensity rather than caring status alone, because caring intensity is probably likely to offer a more helpful picture about the impacts of caring. And then finally, given what we know about widening inequalities, we think it's really important that we try to unpack the role of socioeconomic status in unpaid caring. And Laurie, who is the third presentation, she's going to tell us a bit about how we've started doing that. So if you'd like to read the full paper, here's the link. The maps are also available here, and we'll drop that link in the chat as well. I'm happy to answer any questions. I'm probably not going to be here for the rest of this webinar, unfortunately, but feel free to email me or put the question in the chat and I can respond at a later point. Thank you.
Thank you, Gemma. Thanks very much for that. So we do have a question in the chat, which is from Debbie Price. It says, did you look for or find any differences by whether care was co-residential or not? Thanks, Debbie.
Thanks, Debbie. I don't think we did actually. There was a little bit of evidence around the relationship where you might be able to infer some co-residency, but certainly I don't recall that being something that we found as an explicit subgroup analysis.
Thanks, Gemma.
Sorry, Joan. Though just to add, in the next in one of our other pieces of work, we did find there was a difference in being a co-resident carer between wealth groups, with those the poorest carers in the poorest wealth group rather we're more likely to be co-resident as compared to those in the richest wealth group.
Thank you, Laurie. Another question is from Laura McGarrigle, which is, how is caring intensity measured? Is it just hours per week?
Yeah, so hours per week, and it's usually split into It will differ depending on the cohort data set or how the analysts have split it, but usually 50 or more hours a week is typically the highest group. And I think the lowest might be something like less than 8 hours. But yeah, it's hours per week, usually split by, I don't know, quintiles or something like that.
Thank you, Gemma. I'm going to go with one more question before we move on. And as I said, we will seek to answer all the questions after the webinar, but I'm keen to make sure we've gone through all the presentations because Laurie's data is really interesting, I think, as well. So the one more question from Paul Burton, which is, do we know to what extent quality of life for unpaid care has been impacted by the cost of living crisis? I don't think that was our question, but it's, yeah.
Not in this review, because a lot of the studies predated the current cost of living crisis, but certainly I think that's definitely something that we need to follow up. And I think Laurie's presentation is going to allude to some of these issues around financial security. Yeah. But yeah, fully endorse the question. I think it's something we should be looking at in future.
Thank you. Thanks, Gemma. So I'm going to move on to Alex now. Tim, I've seen your question as well, so it might be something I can integrate as we move forward. Alex, if you go ahead.
Thank you, Jane. Just get my slides up. Okay, so hopefully that all looks good to you. Thank you, Jane. I can see you nodding. That's great. Thumbs up. Excellent. So thanks very much. So my name's Alex Hall. I'm a lecturer in the Division of Nursing, Midwifery and Social Work at the University of Manchester. I'm going to talk briefly about our rapid mapping review of evidence and gaps relating to interventions to support carers. So in this review, we want to identify which carer intervention outcome combinations have an evidence base within peer-reviewed evaluation studies and which don't. We took a rapid approach to mapping the evidence using the software called EpiMapper that Gemma's just mentioned, and I'll show you in this presentation what some of those maps or matrices look like. We also wanted to see the extent to which equity of outcomes has been considered in the literature. So we used a framework called Progress Plus. This is an acronym to capture key characteristics relating to equity. So it includes things like place of residence, race, ethnicity, occupation, gender, socioeconomic status, etc. So similar to the review about the impact of unpaid caring that Gemma has just summarised, once again, we were interested in either carers of older people or in older carers supporting any aged care recipient. We were interested in a range of different interventions, including physical, psychosocial, advice and educational interventions. And we looked at any outcome relating to mental health, physical health, carer burden, financial well-being, social well-being, quality of life. We were specifically looking for quantitative evaluation studies only, so specific quantitative designs. There's no qualitative evidence in these maps. We were interested in evidence from high-income countries published in the last decade. So in total, we included 205 studies. So I'm not expecting you to read all of this table, but I'll just highlight some key messages here. So the majority of studies focused on carers of older people. They're focused on two specific types of intervention, therapeutic interventions and education interventions, on two specific types of outcome, so mental health and cognition or carer burden. And there was also virtually no consideration of equity in outcomes in any of this literature. So the maps produced in EpiMapper look like this. So they are interactive, as Gemma mentioned. So if you want to access them, you can look at the QR code, and they're also available in our paper, which has been published, and a link for this will be available at the end. So here's a map charting the interventions across the top by outcomes down the left according to population. So the key at the bottom is very small on this slide, but the blue circles refer to studies involving carers of older people. The pink circles refer to, the green circles refer to older carers, and the pink circles refer to both. So the larger the circle, the more the studies. So we can clearly see that the evidence tends to focus on carers of older people. And to give an idea of relative size, the largest blue circle in the cell towards the top left, which is therapeutic interventions addressing mental health outcomes, that's 37 studies. So if you access these interactively, if you click on a cell within the matrix, it will then bring up a list of the actual studies that are coded within that cell. So this map shows the interventions and outcomes again, but this time it's by study design. So again, to remind you, we were only interested in quantitative evaluation studies. So please bear this in mind when I'm talking about evidence clusters and gaps here. So the colours refer to different study designs. The green circles are randomised control studies, which are the strongest designs, and the pink circles are before and after studies, which have the highest risk of bias. So we can see clear clusters of evidence focusing on therapeutic or education interventions to improve mental health and cognition or carer burden outcomes. So again, to give an idea of relative size, the largest circle is the green circle towards the top right, which is about education interventions to improve mental health and cognition. This was 24 randomised controlled trials. So the very small circles on this map indicate that there were 1 or 2 studies. So the really obvious gap in the middle here relates to interventions to improve carers' financial circumstances. So if we look along this row, we can see very few interventions at all targeting this outcome. In fact, it's just 2, and I think these were part of sort of multi-component education interventions. So some of these gaps are partly understandable if we think about the intervention outcome combination fit. So we may not expect interventions like aids and adaptations or physical therapy to be intended to address carers' financial circumstances. But we know, and as we've just talked about in the Q&A, that carers are experiencing adverse financial outcomes exacerbated by rising cost of living. So there are some crucial gaps here in the evidence about what works best to support carers' financial well-being. The biggest gap in terms of the interventions relate to evidence about the effectiveness of pain management, physical skills training, and any financial information or advice interventions on all outcomes. So one reason for evidence gaps may be that interventions have not yet been subjected to evaluative study. So this could be for reasons around difficulties obtaining funding, the feasibility of doing such studies if the populations are very small, or if the intervention is at a very early development stage and isn't ready for full evaluation yet. Another reason for evidence gaps may also relate to the time frame of our review. So you may have noticed here that we identified few studies evaluating the effectiveness of respite interventions. So we think that this reflects the contemporary time window of our search as we were looking for work published over the last decade. So we know that there's a large body of work about respite published before 2013 that's already been synthesised in 2 high-quality reviews. So respite interventions may not be the focus of contemporary research, or they may this may reflect changing approaches in how we're supporting carers. So to sum all this up, most evidence considers the impact of therapeutic or educational interventions on carer burden and mental health outcomes. So we think that there's a need for focus on interventions to support outcomes beyond these 2. Few evaluations consider how best to support physical health, quality of life, and social and financial well-being. There's very little evidence about the effectiveness of pain management, physical skills training, and financial information and advice intervention specifically. And there is very, very little consideration of equity and inequalities in this literature. So the extent to which any observable benefits of interventions are experienced across diverse groups. So as we said there, the full paper is available. It was published earlier this year, and the paper contains links to the interactive maps as well. So I will stop there. Thank you very much.
Thanks, Alex, and thanks for just explaining how those interactive maps work, because I know sometimes they can look a bit daunting when you first land on one. So it's good to know what the circles do. Are there any questions from anyone? It might be an opportunity just while we're waiting for anyone to post anything. We could just ask Tim's question, which was actually around, is the behaviour of the cared for person as a main stressor, in brackets, linked to worse health? Can I ask Gemma whether that's anything that you did find?
So I don't think, I was thinking about this question earlier. I don't think that would have fallen within the scope necessarily of our review. So I'm not confident to say there's no evidence on that. I don't think that's true. I think it just wouldn't have been within our review. But we know, obviously, anecdotally, that is a huge issue, and I can't imagine this hasn't been evaluated somewhere. Sorry, that's not a very helpful answer. I'm reluctant to commit to say yes or no, or give some indication, because it just wasn't within our review scope. But I think that has been evaluated somewhere.
So, Gemma, just so in our follow-up when we send out, we usually just put any links to any publications that might help answer some of that question. So we'll make sure we do that as a follow-up, if that's okay, Tim.
Definitely.
So therefore, and that's what we've done previously, is just link to any other systematic reviews or reviews that might have happened around that space. But I think I agree with you, it probably has already been covered to some extent, but wasn't the question that we were asking. So for now, and because of time, I can't see any more questions, and I'd like to move on to Laurie's presentation, which does present some of those sort of financial tensions that I think we've started to surface in some of the previous questions as well. So I'm going to pass over to you, Laurie, if you're happy.
Okay, thanks, Jane.
Thank you.
I'll just share my slides now. So can everyone see that? Okay. So this is our a presentation of our work entitled Characteristics of Older Unpaid Carers in England, a study of social patterning from the English longitudinal study of ageing, which we recently published in Age and Ageing. So in terms of background, the scoping review that Gemma mentioned found that whilst there is a lot of research around unpaid carers in the UK, very little has considered how carer characteristics and health outcomes vary with socioeconomic status. And this is an important gap because of the expected rise in the number of older people providing unpaid care. So addressing this gap will inform policy efforts to help develop meaningful support for older carers. So with that in mind, we aim to characterise the demographic profile, health, well-being and care needs of older unpaid carers, and then explore if and how these characteristics are socioeconomically patterned. So to do that, we used data from Wave 9 of the English longitudinal study of ageing, which was the most recent study wave at the time of conducting the research. And with this data set, we then drew a weighted sample of 1,282 unpaid carers aged 50 or over, which we defined by an affirmative response to the question, did you look after anyone in the past week? By look after, we mean the active provision of care, and we did that in accordance with previous research. We defined socioeconomic status using total net non-pension wealth cut into groups, because wealth is believed to be a robust indicator of socioeconomic status in studies of middle-aged and older people. We then examined the characteristics of unpaid carers through descriptive statistics, and then compared the characteristics of carers in the poorest and richest wealth groups using logistic regression adjusted for age and sex, and the middle wealth group as the reference. And then we presented our results in a forest plot, which I'll go through on the next slide. So in terms of explaining this plot, symbols on the left-hand side of the red line, which you can now see here, are less likely to occur, whereas those on the right-hand side of the red line are more likely to occur. The further away the black dots are from the red line, the more significant the outcome is, and the narrower the black lines are, the more precise the estimate is. And if the black lines cross the red line, it means that the outcome wasn't significant. So the poorest and richest wealth groups are both referenced to the middle, and I'll run through what we found for the poorest wealth group first, who are shown on the left, and just read the plot from top to bottom and highlight a few examples of what we found. So in terms of health-related outcomes, unpaid carers in the poorest wealth group were more likely to experience feral poor self-rated health, loneliness, chronic pain, a higher number of diseases and dependency, but were less likely to report a good quality of life. In terms of demographics, they were more likely to report their ethnicity as non-white, in line with previous research that has described clear variations in caregiving by ethnic group, and they were more likely to be age 66 or older. In terms of caregiving relationships, carers in the poorest wealth group were more likely to live with the person they care for, and they were also marginally more likely to look after a spouse, this being on the cusp of statistical significance, but less likely to look after a parent. We don't know what the reasons for this were, but we thought it might be related to the earlier onset of ill health and mortality in socially disadvantaged populations. For several of these outcomes, the converse was true for carers in the richest wealth group, who are shown on the right-hand side of the plot. For example, they were less likely to experience better poor self-rated health, chronic pain, multimorbidity and dependency, but more likely to report good quality of life. In terms of demographics, they were more likely to be younger, and in terms of caring relationships, less likely to live with the person they care for, less likely to look after a spouse, but more likely to look after a parent. Other outcomes not shown on this slide were non-significant and were common to the unpaid carers irrespective of socioeconomic position, and these included the non-receipt of carers allowance, the hours spent caregiving, and anxiety symptoms, and carers in all wealth groups are also more likely to be women. So in summary, we concluded that unpaid carers experience adverse outcomes, which are often socioeconomically patterned. So in terms of the implications of this work, we concluded that financially disadvantaged older unpaid carers and their households may have the greatest needs for intervention and support. So focusing resources on this group has potential to address social inequalities. So whilst there is a lot of evidence about ways to support unpaid carers as a whole, which Alex mentioned, there is little evidence specifically about what approaches work best for financially disadvantaged older carers who might find it harder to access support, both for themselves and for the persons they care for. And future research could help to inform intervention strategies to support financially disadvantaged older carers by providing a more in-depth and nuanced understanding of their unique needs and experiences, including by incorporating marginalised groups into the research. Thank you very much for listening. I'll stop sharing now.
Thanks, Laurie. I think really insightful piece of work, especially when we think about the recent announcements around the number of carers and, that were featured in the Darcy review. So thank you. Another question from Debbie. So very interesting, curious about whether perhaps the wealthier families were able to access simultaneous paid care, which might help. Were there any evidence or questions around that?
We didn't look at that in the data set, but it's quite likely that was the case, but we can't confirm either way from the data that we had.
Thanks, Laurie. But again, it would seem certainly being wealthier enabled people to cope with their caring responsibilities, maybe. And then just a further comment from Tim there. Are there any other reflections? I've had a quick look in the chat. I can't see any other questions or comments. Okay, just because of time, I'm going to move on now, which I think is myself, I'll be presenting, and I'm looking at a stakeholder workshop that we're going to do. So I'm just going to share my screen. Do keep questions coming, and I will keep an eye on them once we get to the end of this, and we can have further questions at the end once I've done this section now. So it won't be a second. I'm just going to get myself set up. Just give this a minute to. There we go. So that should now be visible for everybody. So I'm going to build on the research that we've just heard about. I'm going to talk through the findings of an interactive workshop that we held as a final stage of this whole piece of work. So specifically, we invited a group of key representatives from across the voluntary and advocacy care sector to review and discuss the findings of the review work that you've just heard about. Sorry, just move across. So our approach to the workshop included participants identified as those who worked really closely, excuse me, with carers of older people in their respective organisations. To maximise diversity, we sought representation from national, regional and local bodies, and those who were supporting carers from across home and institutional settings. We initially identified 14 organisations using existing networks of the Policy Research Unit. We wrote out to each organisation explaining that the purpose of the workshop was to reflect on the findings of 2 rapid evidence reviews concerning unpaid care, including the impact of caring and the best way to support carers. The workshops took place online, notes were taken by all the research team members, and subsequently they were collated and then summarised. These were then categorised and themed, and a draft report was prepared, which we circulated amongst the participants for review and confirmation. So we had a total of 7 attendees who were working in areas of high levels of deprivation and with ethnically diverse communities. So that included Wakefield, Leeds and Manchester. The reach of those represented included 3 national organisations, 1 regional caring organisation, and then 3 very local organisations. Participants were working in a really broad range of job roles, but with key priorities for working to support older carers and carers of older people, with including a range of needs of those being cared for. So that included people living with dementia and also people that were caring for adults with learning disabilities. The workshop commenced with brief presentations of the findings from the review work, very similar to what you've heard today. This was followed by a discussion, firstly, to look at the gaps in evidence identified, and secondly, for any other perceived gaps in evidence that were not otherwise captured by the research and which participants thought needed to be addressed for the future. So as a result of the discussion, in addition to the 2 themes that we've already heard about today that we'd identified, a further theme was added, which was exclusive to the workshop and covered the structural and system level insights around carers' lives. So we named this the impact of the care service environment on carers. And I'm now going to talk through each of the issues and what came up within each theme. So first of all, if we're building on the gaps identified in the review work, which Gemma talked about earlier, the workshop respondents have advocated for future research to really address social outcomes for carers, as well as the longer term consequences of caring on health and on career progression. Respondents discussed the importance of the transition from caring to no longer caring, which could have been driven by bereavement or by the careful person moving into a residential care setting, for example. And this was a need for research into the immediate longer term impacts on health, well-being, employment and finances. So those transition periods, and what does that really mean for people? In addition to these gaps, respondents also identified other priority areas that we did not find in the review work analysis. So these included understanding about the impacts of the pandemic, alongside the consequences of reduced care home uptake on carers. Some groups were thought to be hidden from current carers research. This included people that were caring for those with more stigmatised issues, such as substance misuse, mental health issues, or neurodiversity, such as autism. In terms of how to support carers, so outlined by Alex as well, one of the gaps that was identified in the review was about the impact of befriending services for carers. Respondents really agreed that this was actually a critical area of support, and building on this, the group actually advocated for really focused befriending role where one-to-one peer support could actually really help new or more isolated carers to navigate the systems and the help that is actually available for people. Digital social platforms such as WhatsApp groups were also cited as a form of support that became more common during the pandemic. So again, future research could really aim to understand about the impact of these digital support options for carers. Beyond this workshop, respondents went on to propose novel options for supporting carers. So for example, the group discussed the potential expansion of housing with on-site assistance. So that would allow carers and care recipients to stay together whilst giving respite options that were really accessible for people. So finally, with reference to the third theme, where respondents identified a need for greater evidence related to the structural and system level impact, priorities here really described a need for a much more granular and deeper understanding of the impact of the precarity of social care resource and provision on carers themselves. Additionally, a need for evidence and insight about the uptake and outcomes of carers assessments and of the nature, variation and impact of healthcare trust policies for carers individually, and what does that mean, and what's the impact really on both carers but also care recipients. That was felt to be of really great importance to those people that we spoke to. Evidence and insight about these issues reflects the role of policy-driven structural determinants of health more broadly, and were really argued to provide critical contextual insights about the lives of unpaid carers themselves. So just to quickly summarise, in addition to the gaps identified in the review work, several further priority research areas were identified by our participants, including research focusing on longer term impacts of caring, the pandemic focus on hitting carers. There is a need for evidence about the impact of societal population factors on carers, so understanding the impact of the changing welfare policies and care provision over the short, medium and long term will be really essential to help inform how we seek to ensure the health and wellbeing of unpaid care is prioritised. As carers occupy really increasing roles in supporting ageing populations, we can expect to see a greater consideration of their care needs, their needs over a number of different policy spaces. Policy and practice to support carers must be informed by evidence, and such evidence must be timely, novel and meaningful. And we appreciate there are some limitations. The workshop only had 7 participants, and whilst we did really aim to include diversity of the carer experience through inviting those who are actually advocates for carers, it remains to be a limitation. Future research in this area will really need to ensure the voices of carers and their lived experience are central to shaping the future research agenda. So I'm going to finish there. I'll stop sharing my screen. And just kind of want to ask if anyone's got any further comments or questions for the group here today. I think Linda's been busy sharing different links that should be available. I think she's shared the website, the web page, which hopefully should be useful to people. Thank you, Linda. She's also shared the journal articles. Has anyone got any questions? I'm just moving between the 2 different chat rooms. Can't see anything. Just give anyone a minute. Okay, so if there aren't any further questions, and there doesn't appear to be, I'd just like to thank everybody for attending the webinar. We're really pleased that people came today. We know this was rescheduled, so we're really welcome everybody's contribution. Thank you to Gemma, to Laurie and to Alex for presenting, and thank you, Paul, for your comment in the chat. I just want to remind everybody that we have webinars every month where we share our research. So the next one is on narrowing the gap in disability-free life expectancy, and that's taking place on Wednesday, the 16th of October between 12 and 1. And then the one after that is one on bridging perspectives in home care, and that will take place on Wednesday, the 20th of November. And Linda has kindly popped the links to those in the chat if anybody wants to register. As I mentioned, we will be producing a short video of today's session, which will go up into our YouTube channel, and anything that we couldn't respond to, and I think it was Tim's question really, we will share as a document link to that, and we'll follow up. But thank you very much for your time, everybody. And yeah, thanks to the speakers.